going to go ahead and get started here. There's a couple extra seats if anybody needs up front here, but there should be enough. So I'd like to welcome everybody tonight to our symposium on shoulder instability, hosted by Southeastern Orthopedics Sports Medicine and Shoulder Center. We like to put on a few of these symposiums each year on different shoulder topics, tonight being shoulder instability. And just to kind of give you a little forecast of the different things we'll talk about tonight, we're going to start with talking about the pathoanatomy and physiology of the shoulder and the areas that help and contribute to stability in the shoulder, as well as surgical treatment approaches to shoulder instability. Then we'll talk about the treatment post-operatively from a rehab standpoint for folks who have surgery in regards to shoulder instability, shoulder reconstruction, labral repairs, those sorts of things. And then lastly, we'll discuss conservative treatment for shoulder instability non-operatively. All right? So just to kind of give you a little background about each of the folks presenting this evening, Dr. Kevin Speer is an orthopedic surgeon here at Southeastern Orthopedics. He performs surgery exclusively on shoulders. He did his undergraduate work at Indiana University, followed by going to medical school at Johns Hopkins. And then he did his residency, both general surgery and orthopedic surgery at Duke University, followed by a fellowship in sports medicine and shoulder at the Hospital of Special Surgery in New York, or HSS. Dr. Carrie Smith did her undergraduate work at Duke University. She's a physical therapist here with us at Southeastern Orthopedics. She's been here for about 4 years, and she went to the University of Miami for PT school. So, that being said, we're going to get started. Hopefully, each section will maybe take about 30 minutes. If you could hold your questions till the end. At the end, we'll do a question and answer sort of session, and more so just any ideas, thoughts, things we didn't cover, or stuff you've got questions about or want to bring up. We just encourage you to talk about it, and sort of we can gain some understanding together about different things. All right, so I'll introduce Dr. Speer at this point.
Thank you, Paul, and welcome. Tonight's symposium is on shoulder instability, and my task is to sort of certainly speak to you from my perspective, which is as an orthopedic surgeon, talking to you more about pathoanatomy and pathophysiology, some surgical indications, types of surgeries, and sort of basically setting up the two subsequent talks. Carrie's going to speak next on the physical therapy, the rehabilitative effort following a surgical reconstruction. And Paul's going to finish more on the rehabilitative effort in a non-operative setting or attempting to avoid surgery. So much of my talk too is to try to emphasize and reveal, the central importance of physical therapy in treating these patients, whether or not they have surgery. So as I said, I'm going to talk about some pathomechanics of shoulder instability, and then we'll get to some the other considerations, both non-operative and operative. But first we'll begin with anatomy, which I always think is a good place to start. And just as a reminder, it's an x-ray of a shoulder, and this would be, say, looking at it, would be a left shoulder. So the humeral head, the glenohumeral socket, the glenoid here, and there's a little projection here called the coracoid, the clavicle on the top, articulating with the acromion, the AC joint up here. So here's would be a typical x-ray of a shoulder. It's dislocated anteriorly. This would be a right shoulder. So the humeral head is out the front. There's the coracoid, there's the collarbone here. So this is sort of, when here someone has a traumatic shoulder dislocation, this is what it looks like. The outer layer of the shoulder, the musculature, just as a quick review, which is the relevant part to physical therapy for it, of course, is the rotator cuff, both anterior and posterior, subscapularis in the front, then the biceps tendon, and then in the back, the supraspinatus, infraspinatus, and teres minor. One noteworthy fact that's just done through research over the years, but in terms of the potential for force, and there's ways to calculate that based on cross-sectional area and the size of muscle, volume of muscle. The subscapularis tendon, in terms of potential for force, equals supraspinatus, infraspinatus, teres minor combined. So with the shoulder, you talk about force couples. And later you're talking about stability of the shoulder through rotator cuff strengthening, and the importance of force couples. The shoulder is balanced across the biceps. So everything in front of the biceps balances everything behind the biceps. And don't forget, and later we'll talk more also about the scapular muscles, the periscapular muscles, rhomboid, serratus, latissimus, things like that. Now let's go one layer in. Now this is the layer, for the purposes of tonight's talk, this is the layer of the pathoanatomy, the structural distortion, the injury. So looking head on into the glenolateral socket, there's the glenoid. It's surrounded by this sort of fibrocartilaginous rim called the labrum, in which all the ligaments attach to. And this is a relatively, even though it's a cartoon, this is better than some depiction. It sort of seems like this sort of confluent capsule. There's named ligaments, the middle glenohumeral ligament, superior glenohumeral ligament, inferior glenohumeral ligament. When you look at it arthroscopically, it sort of looks like that. It's sort of confluent. I mean, you can find landmarks. You can say, well, here's the band, the inferior glenohumeral ligament, and below this is the capsule or something like that. Below this is the rest of the ligament. But it's basically a confluent sheath with little ripples and folds in it that has become named over time. And this, I thought, was a very relevant slide. Is that so? Here's a humeral head and the socket. So imagine the deltoid is stripped away, the rotator cuff is stripped away, and all you have is ligaments. And so basically, this is the ligamentous system. It's a sleeve that is circumferentially around the humeral head, attaching the edge of the glenoid labrum to the anatomic neck, or the edge of the articular cartilage of the humeral head. And it's this sleeve. So here's where the pathoanatomy is. And now normally, the amount of volume, and this is actually pretty nicely depicted because you can sort of see there's a lot of room in there. So normally the amount of volume in the shoulder joint is enough to contain 2 humeral heads. So the shoulder has a lot of laxity in it naturally. It has to, because the shoulder has more motion than any other joint in the body. I mean, that's sort of the way it's designed. And one last thing about getting to pathophysiology, before we start getting into some other things, is that the ligaments in the shoulder, when they're traumatized, plastically deform. So the 2 great examples of how ligaments tear in the body, the 2 extremes, would be the anterior cruciate ligament and the glenohumeral ligaments in the shoulder. So when the ACL tears, if you've ever seen a picture, if you've ever observed surgery, it's explosion. It's physical distortion that is irreparable distortion. Shoulder ligaments, very different. They stretch, just like saran wrap. It's plastic deformation. And many times when you look at them, basically the chronic scenario, it's hard to tell how much it's been injured. I mean, is the ligament 5 centimeters long or 4 centimeters long? I mean, it's a matter of volume and capaciousness. So that therein lies some of the challenge from a surgical perspective of getting these capsules tensioned correctly, because of the nature of how the glenohumeral ligaments tear. I usually think of shoulder instability into 3 types. There's the macro instability, so something big has happened. Usually big has happened once, and from that point on it's rendered a problem, or potentially a problem. Macro trauma, it can come out entirely, dislocation, it can come out partially, subluxation. So micro trauma, which means something much smaller, that happens numerous times. The most classic example has to be repetitive overhead sport. Swimming, baseball, volleyball, stuff like that. And then finally, stuff that just happens. It's the way that God made you, which means somehow someone has enough laxity in their shoulder. So laxity is a normal physiologic term. The shoulder has a lot of ligaments, have a lot of laxity. And the humeral head volume is such that it can contain 2 humeral heads. So that capaciousness, if it's distorted a little bit, suddenly becomes unstable. So instability is a pathologic term. So when laxity becomes too much, it becomes instability or a multidirectional instability. And that could be immensely challenging to treat surgically, sometimes challenging to treat non-surgically, but still it's something that we're forced to contend with. So a shoulder dislocates anteriorly through numerous traumatic mechanisms, as you can imagine. So here's such an example of the humeral head, the glenoid in the socket that's come out the front. And if you do a cutaway here, so again, this would be the glenoid, this would be the labrum. The labrum is where the ligaments attach to the glenoid, but it's its own sort of fibrocartilaginous thickening. It increases the depth because the glenolateral socket has a depth to it that is increased 50% by the labrum itself. And that depth, that concavity, enhances the capacity for the rotator cuff through concentric forces to get a good reduction and maintain stability, because you need a socket. You need a concave socket. And the glenoid labrum make it more concave. And this is sort of the classic, so it dislocates out the front. It typically tears the labrum from about equator down, and the eponym for it is a Bankart lesion. Of course, this was described, I think, like 1912 by Dr. Bankart, but anyway, it's ascribed to him. The other thing that occurs in there, and for the purposes of this slide, ignore this multidirectional instability. This was the only slide I could find that showed capsular looseness, capsular laxity. But, so here's a normal joint. Here's the biceps tendon. This is sort of reflecting a normal capaciousness of the joint. There's some redundancy there. And then when the shoulder dislocates, this thing gets stretched out. So then it looks more like this. And it's definitely weakened because it's stretched out. So again, ignore the multidirectional instability. And what we'll talk about a little bit later, but I'll preview it now, is what heals? When the shoulder dislocates, the ligaments get stretched out, so they're more stretchy. So at least temporarily, there's more volume, there's more capaciousness in the shoulder for the shoulder to come out of joint, and the cartilage tears. Well, cartilages do not heal with time, or physical therapy for that matter. The ligament, that can heal, and that can shorten. And one of the reasons is why is this ligament, on the outside of this ligament, is a nice vascular muscle envelope. Very good healing environment. So the ligament itself can heal if it's been traumatized, but not a labrum, not a cartilage. Now that's not the only thing that can occur in a shoulder, or one that could be injured in a shoulder when it dislocates. Don't forget nerve injury. It's uncommon. This sort of depicts the potential brachial plexus injury, but it's mainly the axillary nerve. It's something always to be on alert for, that someone is dislocated, you're seeing you in your clinic, and you get an assessment of how strong their deltoid is. The deltoid has a little area of sensory distribution right here that's helpful as well. So usually that deltoid, the axillary nerve dysfunction, has a lot to do with how long it was out of joint. Someone dislocates, and it, God forbid, it takes them 3-4 hours to get it back in the joint. That's a real problem, or it could be. Those recover, thankfully, predictably, thankfully, usually within 90 days, thankfully. But it's an early source of morbidity, and it's really something to pick up on because it can confound your early rehabilitative efforts. Now lastly, the other thing that can occur when the shoulder dislocates is the rotator cuff tendons can tear. Here's the humeral head. This would be the subscapularis, the supraspinatus here. So we're not talking about this tonight. I mentioned this because so basically we're talking about a population of people probably below the age of around 40-ish, that when they dislocate, we're talking about capsular labral pathology, ligament injury, labral injury, not rotator cuff. That's a different symposium. It's not for tonight. And to include rotator cuff tonight is too long of a symposium. But you take a 50-year-old and have a traumatic dislocation, they're typically not going to tear the labrum. They may tear the ligaments up. They're going to rupture their cuff. So what's interesting is, and that's a good example of what becomes the weakest link in the chain as we get older. So if you have an injury mechanism in which someone is going to tumble to the ground, have an abduction external rotation mechanism, and have a force to come out the front. In a 20-year-old, the weakest thing in the shoulder is the ligament and the cartilage. That's why that tears. In a 50-year-old, the weakest thing in the shoulder is the rotator cuff tendon. Not that the ligament and the labrum are stronger, it's just that as time passes, things get softer in the body. It's senescent change, age-related change. So in a 50-year-old, generally, the shoulder's going to, the rotator cuff's going to rupture. In a 75-year-old, same injury mechanism, they're going to proximal humerus fracture. And it's not because, well, it's 75, so the rotator cuff is stronger. Oh no, the rotator cuff is a lot weaker at 75 than it is at 50. Just the bone is even weaker. At some point, generally speaking, a chain breaks at one link. Generally speaking. So tonight's talk is on capsular labral instability, and it's very mechanical problem for orthopedic surgeons. It's well suited to arthroscopic techniques, and basically this is what you have. You have the bony socket, you have the labrum, which is the cartilage, which is detached from the bone, attached to the ligament, and you have to reattach this to there. It's pretty straightforward. It's not as complicated as rotator cuff repair. It's not as complicated as fracture fixation. It's really not. It's basically just putting things back together where they began before the injury. The shoulder can also go out the back. Less common than the front. And usually the back is a fallen or an outstretched arm. So it's a very specific mechanism. It's more the shoulder is forwardly elevated, generally, more in a straight plane like this, fallen or an outstretched arm, and the shoulder can dislocate out the back, or more commonly subluxate out the back. Pathoanatomy just gets reversed. So here's the glenoid socket or the glenoid, and the humeral head's out the back. This is what the X-ray looks like. The one thing about dislocating out the back is when it goes out the front and it comes out, it usually goes subcorpus. It kind of goes out the front and it kind of locks out. And many times it's not, it's more obvious to push it in and out. When it goes out the back, it's more of a continuum. So there are some people who have a posterior instability who after a while, it's amazing, they can just pop it out the back, reduce it from the back. Pop it out the back, reduce it out the back. Some people think it's kind of cool. This is such an example. Someone's laying on his back, here's his axilla, of course, his arm is going up here, his elbow would be up here, and he can make it come out the back. That's a challenge. When someone can, through postural manipulation, make it come out the back, that's a challenge, because the problem is multifold. There's pathoanatomy, there's the needfulness of some rehab and strengthening, and there's some education that you got to stop doing that. Right? Posterior instability. So here, here would be an MRI, MRI arthrogram. So we put a little water in the joint, and here's the front of the shoulder, the back of the shoulder. This is the biceps tendon up here, and these little arrows show the tear between the posterior glenoid and the posterior labrum. And basically, you just you repair this back into there. And arthroscopic surgery is very nice for that, and it's well suited. The other component is a multi-directional instability. This is challenging because this is, first of all, a lot of people have a hyperlaxity. You know, everything in biology is a bell-shaped distribution, everything. And the amount of laxity in the shoulder is such. So you get someone who's 3 standard deviations beyond, you know, the mean laxity, they have a lot of laxity. You know, so typically you're thinking adolescent, young, female. So a lot of laxity, maybe other joints exhibit it, you know, elbow hyperextension, patella hypermobility, stuff like that. Then you take that kind of joint and you perturb it, perhaps slightly, perhaps just trivially, you know, a volleyball play, some repetitive play, or it could be from an injury. And then the shoulder gets out of balance, or, and the rotator cuff becomes sort of not as compensating, and then you get the shoulders having multiple recurrent problems of instability in multiple directions, which is a real problem. So those kind of shoulders have a ligamentous system that has extra capacity. If the ligament measured linearly should be 3 centimeters, theirs is 4.5. And part of it's the way God made them. And therein lies the great challenge from a surgical perspective. So, well, if we do multidirectional instability, we try some physical therapy, didn't get them better, we're going there, we're going to tighten up these ligaments. We know how to tighten them up, it's pretty straightforward. We know how to tension them, pretty straightforward. They're usually young, healthy people. You know, so healing should be a predictable occurrence. The problem is the body is hardwired for this much capsular laxity, so they stretch out, which is a problem. You know, so the notion is, well, you know, don't over tighten the shoulder. You might make it stiff. That's true, except for this kind of shoulder. And these shoulders, it's hard to get them over tight. In fact, you try to get them to stiffen, and many times they do not. Most times they do not. Quick mention about internal impingement, another type of variant. In the shoulder, in the microtraumatic shoulder, the shoulder which you're getting plastic deformation in the front of the shoulder, and so there's more capaciousness in the front. In a shoulder that is winding up to do something overhead, could be baseball, could be volleyball, could be tennis. I suppose it could be swimming. I don't see as much in swimming. Inside the shoulder, the undersurface of the supraspinatus tendon abuts or contacts or impinges on the posterior superior labrum. That is the impingement we're talking about. So the impingement of internal impingement is the supraspinatus tendon and the posterior superior labrum hitting like a nutcracker. It occurs because the anterior capsule has gotten plastically deformed. So even though the pain is from this, perhaps, this abutment, the pathoanatomy is much more extensive. It has a lot to do with pathology, ligamentous laxity, or plastic deformation, labral tears, partial tendon tears, sport mechanics, all measures of things. And sometimes the posterior capsule is tight. So again, these are usually overhead athletes. There's a pathologic anterior capsular laxity. There's a glenohumeral internal rotation deficit. The posterior capsule has specific motion loss. And it's a phenomenon of the overhead athlete. Most overhead athletes, a lot of studies have shown that they have increased external rotation. Well, it's not that they have increased external per se. I mean, they do, is that their whole motion arc shifts. So their external rotation increases, internal rotation decreases. But sometimes that internal rotation decrease becomes problematic. And therein lies a problem. And some young athletes, that's a real issue. And they're doing a lot of stretching, that posterior capsule, to keep their shoulders from breaking down in terms of rotator cuff tendon-based symptoms with their sport play. So non-operative treatment, which we're going to get, well, certainly post-operative treatment, as well as the non-operative treatment that Paul and Kara are going to speak to, is this, right? It's muscle. You know, you're strengthening the stabilizing elements. The ligamentous system in the shoulder is such that, so again, let me back up. All shoulder motion is rotational. It's not translational. So there's a dot in the middle of the humeral head, and I'm moving my shoulder around in space. It shouldn't move but 1 or 2 millimeters in either direction. The ligaments don't really tense and come into play until you're at near end range of motion. So certainly for the 80% of the inner sphere of motion, so my motion arc and all this here, all that stability is predominantly rotator cuff. Now there's some other elements, there's some adhesive components and some and all that, but the ligaments are not taught. They're taught at in range of motion, not central range of motion. And so getting the shoulder rotator cuff muscle stronger, getting the scapular platform muscle stronger, super important. Super important. You're going to hear all about that a bit later. This is I thought is a good illustrative slide to point out. So what the challenge for you all as physical therapists for shoulder instability, again, we're not talking about cuff tears now, is that the pathoanatomy is this. Here's the humeral head. It's this sort of labral ligamentous sleeve that you cannot influence by your physical therapy. So you're trying to get patients better indirectly by strengthening things and hoping that creates a compensatory balance in the shoulder that results in clinical improvement. So if someone is clinically unstable and having problems, and they send them to physical therapy, and you do your therapy, and afterwards they're doing fantastic. That's awesome. That's the objective. But if they had a cartilage tear, it's not healed. If they had ligament plastic deformation, it's unlikely to have changed much. Maybe a little bit, but not much. But you know, it works. It works, and getting the scapular muscles stronger as well, and being sure that especially for the overhead athlete, if they're having problems with anterior instability, be sure that the back of the shoulder is not tight, pushing it out. Be sure they don't have any GERD, glenohumeral internal rotation deficit. Always be aware that the back of the shoulder can push the front of the shoulder out. And sometimes that's not so easy to discern, and it takes some time to really measure it to convince yourself that it's real. Another challenge of non-operative treatment is bracing doesn't work so good. It's not like an ankle. I mean, you can have a pretty ankle, and you can stabilize it in many ways. I mean, if someone dons a shoulder brace and indicates that it helps them because it restricts their range of motion. Because the shoulder is going to come out of joint at a certain motion arc and rotation. Okay, so if they can't get there, well then they're not going to come out of joint. So it's limiting functionally. So what makes the shoulder hurt though? Why do they have pain? Shoulder hurts for 2 reasons with instability. One is bursitis. Lots and lots. Everything in the shoulder causes bursitis. Bursitis is a common pain generating pathway in the shoulder. Instability causes it. Anything that tweaks, disturbs, or makes the rotator cuff tendons unhappy causes bursitis. And bursitis is part of the ache, pain, and discomfort in this condition, especially in the overhead athlete. You have a 19-year-old baseball pitcher who has shoulder pain, and their problem is pain. They are unlikely to articulate words and voice concerns that make you think instability. You just have to know it. It's not like, I feel it slip or slide or move or come out of joint. I feel it pop or click. It hurts. So why would a 19-year-old otherwise healthy person have a recurrently symptomatic and painful rotator cuff? They probably have some microinstability. The other reason that shoulder instability hurts is that these torn labrum can actually hurt if they're mechanically and structurally significant enough. A lot of times they have pops, the pops hurt. The question is the popping because the labrum, or could they have some bursal adhesion that pops? Who knows? But anyway, I do think labrums can hurt. The indications for surgery are pretty straightforward. They're not getting better without surgery. And they need a shoulder that's stable. Certainly athletes are going to have to if they're going to participate, or any lifestyle that demands a stable shoulder. And it could be anywhere like someone who has posterior instability who has to be physically active and train, say bench pressing to keep strong. So, my patient who's a police officer who recreationally dislocates his shoulder out the back is doing well, but he can't train well enough with bench pressing because it keeps slipping. And his inability to keep his shoulder strong is inconsistent with him passing the training physical to be a police officer. And to keep himself strong enough to keep himself and his partner safe. The treatment is as straightforward as it gets in orthopedics. That which is torn, you put back together, right? If it's too long, if it's stretched, you shorten it. If it's detached, you put it back. It's very straightforward. It's the most straightforward. It's amongst the more straightforward surgeries that we get in orthopedics. And the advent, which we've had forever, 25 years, these suture anchors look like a screw, half a screw with a couple sutures coming out, sometimes 4 sutures coming out. You implant those in the bone, those go into the glenoid. These sutures go through the ligament and labrum, you tie it. Pretty straightforward. It can be done with varying techniques. So again, suture anchors in the bone, sutures come out, sutures pass through the ligament and labrum, and you just tie it. And this brings it together. This is an example of restoring capsular tension. Here's a glenoid, some suture. The sutures go into the tissues. You tie it together, and you sort of get a nice labral bumper and some proper tension in here. Now the challenge is that this construct. So once it's this, say this is nicely constructed. First, for those of you who've never asked the question, and it's a good question to ask, is well, aren't these sutures going to rub on the bone and all that? They don't. Thankfully, they don't. What happens is that they soften, and they get plastered down, and they get synovalized over. So once the surgery is completed, and you get a nice operative construct, if the body heals it in this position, this is awesome. This is going to do great. The question is, that takes 3 months. It takes 3 months. So they can't stay in a sling for 3 months, But they probably should stay in a sling more than 3 days. So that's what physical therapy is all. At some point, and that's why I like protocol. I like some systematic approach towards, yes, we're moving the shoulder, yes, we're rehabilitating and progressing, but we're staying within the area that you're going to respect the biology of the reconstruction. Because a lot of times, even though this surgery is straightforward, and it is, the challenge is the biology is not. Because the ligament and the labrum are one unit together. You're reattaching a soft tissue, a cartilaginous piece of tissue, or a fibrocartilaginous piece of tissue, to bone. So reattaching 2 dissimilar things together, that is a slow heal. It's not like ligament to ligament, tendon to tendon, bone to bone, skin to skin. That's more quick. These are 2 dissimilar tissues. And so it takes every bit of 3 months. And so the notion is that if someone is, you got a 17-year-old stud who's rehabbing and they're 6 weeks out and they look terrific clinically, and they are chomping at the bit to do more, it's like, you can't do it. I mean, that's just the way God made it. It's going to take about 3 months. Open reconstructions work. There's nothing wrong with it. It's not a bad thing to do. I think it's been replaced largely. And part of it is that there's so much more morbidity with an open procedure. Skin incision, delta pectoral incision, through the conjoined tendon. You got to do something with the subscapular. That's a journey down the front of the shoulder. Just to attach the ligament back to the bone that can be accessed so nicely with arthroscopic technique. But there's no. It's not negative. It's just not as commonly done, and I think that the arthroscopic is truly in my opinion, a better approach. Postoperative rehab, which Carrie will get into, is my approach, which I think strongly from interacting with physical therapists of all stripes, to say, okay, in the first month of physical therapy, here's sort of my protocol. What my protocol is that here are the ranges of motion and the allowed parameters. As long as you stay within these guardrails, the shoulder reconstruction that's done should be okay. And which means you may find that you got, again, we'll go back to our, some 25-year-old young healthy kid, or young person, and it may be that our objective is after 4 weeks of the first phase of therapy, as Kara will point out, I want them to be about 40 degrees of external rotation, have about 140 degrees of elevation. You may see them, and after 2 PT visits, they nail that. So then what do you do? Well, at least for my patient, what do you do? Because surgeons every surgeon probably approaches it differently. So I'm best equipped to tell you how I approach things. How I approach things, so if within 1 week of their PT they nail that rehab parameters, then what do you do for the next 3 weeks? Pause. This is not progress as pain allows. This is pause. It's like, wow, you're doing wonderfully. Now I gotta distract you from the tedium and the impatience you exhibit with your shoulder. Then soon we'll start the next phase. But it's not like, well, gosh, you got the whole month of rehab accomplished in 3 PT visits, mainly because you're young and healthy and fit and strong, so enjoy that while it lasts. So then what do you do next? Well, you don't like, at least from my patients, I'm not interested in you saying, well, that's awesome. You accomplished in 1 week what we allowed you for. That is phenomenal. So now let's keep ramping ahead. No. You've got to respect the biology. Because at the end of the day, biology wins. It always wins. We can try to manipulate it. So so if someone is maybe a little stiff or a little weakened at 3 months, that you can manipulate and deal with wonderfully. But if because of our overexuberance or our impatience that we exhibit, and haven't conferred to the patient, if at 3 months their surgical repair has been tweaked and harmed a bit just because they feel so great, that's just not going to, we can't manipulate further healing, through our external means. So hopefully that's a setup for Carrie's talk. I'll bring her up here, and we're talking about the protocol. Again, these are protocols that I use for my patients, and therapists that I work with, Carrie and Paul, use. There are lots of protocols. There are different protocols. I think there are numerous ways to rehabilitate a shoulder that all can sort of find a nice common end result. I really do. But I don't think it's like a cafeteria in which, it's not a la carte. It's like, well, I like this part of Speer's protocol, but I like this part of this person's protocol. And sort of, I think there has to be some uniformity of an approach. So you approach it a certain way. And I have some colleagues who'll take them out of a sling in a week and do X, Y, and Z, but at night they keep them in a sling, and that's all good. In the end, if through their experience it works, it works. So there's more than one way to get these shoulders to heal, recover, and do well. But I do think you have to have a consistency of approach. So tonight, you're going to see our approach, and certainly that's one example of approach. But through time, I think it works. Carrie.